A very good evening and welcome to this meeting of the Adult Social Care and Health Select Committee. I am Councillor Marwan Al-Naji, the Select Committee Chair. This meeting is being held at the Town Hall since regulations that allowed local authorities to hold formal virtual committee meetings expired on the 6th of May. All those participating must be present in person. The event is also being streamed on YouTube channel, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussion that's taking place. To keep everyone safe, can I remind all those present to keep a face covering on and keep it on all the times and remove it only when you are called to speak. You will see that the layout of the council chamber looks different than usual. Members of the committee are sitting to my right of the chamber, and the lead members and officers are sitting to my left here. Any other councillors who are not members of the select committee are sitting towards the back of the chamber. To comply with government COVID regulations and keep everyone safe, we provided protective screening so that are in place between different seats in the chamber, and the seating in the public gallery is limited at the moment. This is to maintain social distancing. Please keep to seating arrangements and follow guidance given about the moving in and out of the chamber. Members of staff are available to help at the end of the meeting. Please leave straight away and do not try to chat in the hallway as normal. However, this is to avoid the spreading of the COVID in this case. Now, I would like to welcome all those in the council chamber and to anyone watching on YouTube. As in all our meetings, I think it will be only appropriate for us to start with a 72-second silence to remember those who lost their lives in the Grenfell tragedy. Thank you. Sorry. Before we proceed with the meeting, I would like to ask members of the committee to only switch on their microphone when they are called to speak, and to turn them off as soon as they have finished. Please remain seated when you are called to speak. Do not stand up, please. If a councillor wishes to speak on a particular item and that has not been called, please raise your hands to get my attention. Now proceed with item A1, membership in the apologies for absence. I note the committee membership and chair and vice chair that were agreed at the last annual council meeting on the 26th of May. Committee members, as circulated in the agenda, they are Councillors Sarah Addenbrook, Vice Chair, Robert Atkinson, Marwan Al-Naji, Chair, Laura Round, Malcolm Spaulding, Charles Williams, and Maxwell Woodger. And we have co-opted members from the Health Watch Central West London, Christine Vigars. Welcome to the committee. Now, we go to the apologies for absence. We have two apologies, one for absence from Councillor Malcolm Spaulding and for lateness from Councillor Laura Round. She will join us later. Before we go to declaration of interest on item A3, any declaration of interest from those who are in attendance? Councillor Williams.
Yes, I have no pecuniary interest, but I am the Council's representative on the governing body of CNWL.
Thank you, Councillor Williams. Please, when you speak, you are allowed to remove the mask slightly and then return it. So I will remind you for that. Yes, Christine Vigars.
I am a co-opted member of the North West London CCG Quality Committee.
Thank you, Christine. Anyone else? No. Before I go on to item A4, select the minutes of the last meeting that was held on the 19th of April 2021, I would like to use this opportunity to thank the previous committee members, Councillor Chauhan and Councillor Idris, for both being excellent members of the committee, and in particular the support I've got from the Vice Chair, Councillor Chauhan, in supporting me during the last year, during very sensitive, very difficult meetings, which we managed successfully as a team. So I extend a warm thanks to both committee members. I will go now to the minutes of the last meeting. The minutes of this previous meeting has been circulated. I believe you had a look on them, and they are, as last meeting, is being recorded for completeness. Do you wish me to sign them off as a correct record, or do you have any matter arising, any correction to make, please? Can I take the minutes then as a true record of the last meeting and sign them off? I'll take silence as an agreement. Thank you, committee members. Will be signed. Now we move on to item A5, and this is the report from the Northwest London Integrated Care Systems. And this is the first monthly update from the Northwest London ICS, which outlines service recovery, COVID-19 response, vaccination, and the ICS development. If members agree, I will take the brief report of the 4 pages being circulated as read. I understand that Janet Cree, who is the Chief Operating Officer of the NWL-CCG, and Dr. Andrew Steeden, the Borough Chair for NWL-CCG, they are here in person to answer our questions. So may I welcome Janet and Andrew. Where is Andrew? Yes. Good evening to you. So, as you know from the context of the report, it's highlighted the service recovery, in particular, the COVID-19 update with the immediate acceleration of the vaccination program and the NW London ICS development, which is really quite heavy issues to take. So now I will take questions from members of the committee first, followed by councillors attending and members of the public. Now, do any members of the committee have questions or comments on this report? So I have Councillor Williams and then Councillor Atkinson. So Councillor Williams, please, your question.
Yes, I think what I wanted to focus on was resources for mental health services, because in the past, we and Westminster, I think, have been had relatively greater resources for mental health services than some other parts of London, and I think the need for that has been demonstrated, and I think it continues to be the case. And could I ask, how will resources be, particularly for mental health, be allocated between different parts of the ICS area?
Who can take this?
I'll make a start. I'm not going to have a full and complete answer for it, but we can. I can certainly sort of give an indication of the position.
Thank you, Janet.
So as it stands at the moment, there isn't a significant change from the way that the allocations have been made historically. So, but over time, what we are wanting to do is ensure that there is equity of provision of service and access to services across North West London. So there will be potentially some changes over time, but certainly in the short term, we are continuing to work with the historical allocations. And you'll see from within the in the report, particularly highlighted is the CAMS requirement, which we know from a COVID perspective has put particular strain on our CAMS services and alongside what we're seeing nationally. And we have got additional monies that are being invested again in across North West London to support particularly the CAMS, our child and adolescent mental health services.
Quickly follow up on that. Yes, I mean, you talk about equal access, but surely it's a question of equal need, and if there's greater need in one part than another, that's where the resources should go.
Yes, yes, absolutely. It's based on a needs basis, but making sure that where there is need, there is appropriate access.
Thank you, Janet. Okay, number 4 question. Councillor Atkinson, please.
Was asking about the question of mental health. Can I say that in future when we get these reports, can we have a few more figures, please? Because I'm not quite sure how significant some of these things are. I mean, on mental health, you say that we're getting an extra 14.4 million on mental health services this year. I mean, what percentage is that compared to the total budget? I mean, is that a lot, or is that a little? It does seem to me, I mean, I note on that same paragraph that there are actually going to be fewer beds for children and adolescents, which, from what I've seen nationally, I mean, this is something we should be worried about, should we not? My second question on numbers is the third paragraph from the end of the report, which I just want to know how we're going to do this. The NHS in North West London has a significant underlying deficit. I'd like to know what that, how much are we talking there? I'd like the figure. It says we're working to understand the drivers of this deficit, and we will reduce costs through increased productivity, which will not impact on the quality of patient care. I'd like to know how you're going to do that. I don't see how having less money, and I'm not quite sure how you can be asked to increase productivity further than you have been. I'd be interested in knowing what ideas you've got in that, and how can you be confident that this won't have an impact on patient care, because it worries me. Finally, I'm just possibly showing my own ignorance, the 1, 2, 3, 4, 5, 6, the 7th bullet point down, to ensure patients get appointments when they need them, we are increasing our offer of patient-initiated follow-ups in line with national guidance. I mean, I don't know what that is. Is that you will be aware and you will have the facility that if a patient is worried, they will have the means of getting a follow-up appointment. Let me know if I've misunderstood that. Thank you, Chair.
Thank you, Councillor Atkinson, for these 3 questions. Who's going to take the 3 or 1? You identify.
I will start, and
okay, thanks, Janet.
I'll hand over to Dr. Steedon to respond about the patient-initiated follow-ups. So note your comments around figures and relativity, so I will feed that back. It's the report, as you Chair alluded to, is the first of what will be a regular report, so it's helpful to get the feedback, and I will ensure that that is considered and taken into consideration for future. With regards, now apologies, I need to now go to, yes, it was around the underlying deficit, wasn't it, that you were then were commenting on. And I think this was one of the areas where it would be helpful to have more definitive figures, and I think probably the reason why the figure isn't in there, it's been quite a moving picture around the finances from an NHS perspective as we've gone through a COVID period, and the way we have been managing our contracts and paying for the contracts has been different to what we've seen in previous years. And that is continuing into this first half of 21-22. But from the second half of 21-22, there will be sort of more traditional or historical patterns of financing and contracting arrangements. The underlying deficit within North West London is made up from both our providers, so the NHS providers, and also from the CCG as the commissioner. So it's the combined impact that is needs to be taken into consideration. And it is significant, and as I say, I don't think it has been fully worked out because we're not quite entirely sure about the income that we will be getting from the centre, but it's in the region of about 500 million. I'm just double checking that was the latest figure, and Andrews, yeah, so around 500 million, so it is significant. The majority of that, though not all of it, is sitting with our provider organisations, and some of that is actually with the resources that we get as a CCG. And the reason why we're working hard to understand the drivers of that deficit is then obviously we can start to address and understand where that has risen from. And the reason why we're having to do that is for exactly the purpose, the reason I stated before is the fact that we have been in quite exceptional financial arrangements during this period of time. And in terms of the ways that we would be looking to increase our productivity, some of that is around the value of us coming together as a single CCG, and also our providers working in collaboration and work together, because we're wanting to ensure we've got greater consistency and standardisation of our pathways and our processes across the whole system. And with that, you do get efficiency, because obviously you're not having lots of different ways of managing it. And I think there is, and that's why it's stated in the update is that one of the things that we will be doing is assessing that there isn't an adverse impact on patient care. The premise on which we are working on is sort of the fabric in terms of our approach is around obviously reducing inequality and learning from the work that we've done through the COVID period to do that, but also levelling up. So where there are areas and where actually we know that there is inconsistency and lower, either a poorer outcome or a lower standard of consistency against the pathway, we are wanting to level up. So therefore, ensuring that we've got the right impact on quality of care is going to be an essential part of that process. And that's why we've also got our the infrastructure, and Christine mentioned that she was a member of the clinical quality committee. So that's one of the key roles in terms of that committee is absolutely to ensure that we abide by those standards. And Christine is there to help us give us that, give the system the assurance of that as well from her Health Watch perspective. Andrew, did you want to add?
Yeah, so I mean that's a very complete answer. The other thing is that coming together, bringing the organisations together meant that we've been able to review the staffing of the organisation, so there have been quite considerable savings there. So we have shared CFO, shared other roles as well. So that's reduced the cost. We do have an enormous degree of variability in various services that are provided across North West London. So what we're able to do for the first time is sit down and work out what causes those, whether that's in primary care or in an acute trust, and then work out what some services are doing well that we can transfer to other services too. And one of the other things that's quite exciting, I think, and particularly for RBKC, is coming together in the local ICP. This is bringing providers together to look at communities and see what they may need, and then come up with a common plan that we can all share, rather than working as individual organisations or providers going forward. So there's a hope that we'll get better outcomes there, as well as generate some savings. The patient-initiated follow-ups is a national plan, and it should be quite exciting actually for patient access, because in those services where the consultant and the patient feels that they are able to manage their access, then the patient is given the details of what they need to do to recontact the consultant. So clearly this is not for acute things, but for some chronic things, I'm trying to think of some rheumatology or dermatology or urology, where you know you're going to have a problem for many years, but you don't need the inconvenience of going to see the doctor to tell him you're okay every 6 months. There's a process where you feel supported by the team and have access to the team when you feel it's required. But having had it explained to the patient and their family exactly what are the type of things that the doctor, the consultant would be interested in them seeing them for as well. So it's just started, and it's rolling out across London. It should be quite exciting actually, I think.
Thank you very much, Dr. Steeden. Yes, follow up from Councillor Atkinson, please. Comment.
The reason I'm concerned about the deficit is that I've been around NHS budgets for a very long time, and I think the things that worry us is that new money and new initiatives have constantly been swallowed up by taking care of old deficits, and I worry that the same thing will happen again. So I wish you luck in terms of innovations and levelling up, but we will certainly need to watch to make sure that things are not levelled down. Thank you, Chair.
Thank you, Councillor Atkinson. Councillor Woodger, please.
Thank you, Chair. My question is, just got a few questions. What's the definition of elective care as opposed to other forms of care? Because I see the figure at one point was 7,000, but it's come down to 4,500. Obviously, we hope to have that cut down. And of that 4,500, what's that made up of? My next question is about cancer care. Obviously, you don't want a significant backlog, particularly of that type of illness where time is of the essence. And if that is the largest priority, what would be the second and third? And also on theatre capacity reducing, how much was it reduced during the pandemic in terms of numbers? I mean, this report isn't bad, but I think that as other members have commented, more figures are always helpful. Thanks.
So elective care is any planned care that's not an emergency. So it would be a diagnostic procedure or an operative procedure, or even some inpatient procedures. So an operation to replace a hip would be an elective procedure, whereas if you fell over and broke your hip, that would be an emergency procedure. So elective procedures are planned. With regard to operating capacity, I think at one stage it was down to almost zero, apart from emergency stuff, because of the need to use intensive care facilities to look after COVID patients and staff to do the same. I do know now there are 3 surgical hubs. Is that right? And it's gradually increasing again. But I don't have the exact figures. We could have those figures for you. With regard to the priorities after cancer, it depends a little bit on the numbers of people who are on the waiting list and the potential harm that they might generate. So there is a process constantly going on, of which I'm a part, where waiting lists are reviewed for harm, and that's to pick up anything that might have changed or deteriorated during a patient's time on a waiting list. What we're also doing is working with primary care to support them to look out for deteriorations and allow them to feed in to the acute trusts if they pick up anything that might suggest a patient's priority has changed. There is a priority setting process that happens at the time of referral, which is then reviewed by the acutes to make sure that they can get the most severe patients through the system quicker, and to review any harm that might be changing during their time on the waiting list. Is that clear?
That's clear. Just to follow up, how do you measure harm?
So there is an algorithm that's used. It's not particularly effective. But it has got an evidence base behind it. So it's a process that happens. I don't know the details of it because it's something that happens in the acutes, but it does look at things like mental health, pain, deterioration of the condition, and likely long-term effects of waiting. So, but I don't know the details. We could get them for you, but yeah.
Thank you. Christine, please.
Part of what I was going to ask has been answered, because I was going to ask about deterioration. But the other part of that is who is actually responsible for informing the patient, because I think there's a feeling that a lot of people at least feel that they're left in limbo. So, I mean, where does that responsibility rest? That's my question. I also have a general comment, which is towards the end of this, you say something about integrated care being as local as possible. Now, I think it's really important that as the system develops, there is a way in which local voices can actually be recognized and fed up through the system so that local concerns are addressed at every level.
So the who's responsible for looking after the patients or informing the patients. Ultimately, it's the trust to whom the patient's been referred. Now, clearly, when the waiting lists were growing during the first and second wave, we had no idea how long ultimately patients would have to wait. What we're doing now is counselling primary care on the kind of advice that patients and families might need to be given at the point of referral, so that we can offer more support to families and patients while they're waiting for their procedure in hospital. But I accept that's a fairly new process that we're adding, so but hopefully it will make people feel more comfortable. The integrated work is getting as local as we can possibly make it. So in West London, we have been working with integrated care teams around practices and PCNs for the last couple of years. And they are then parts of our by-borough, local borough ICP. So we're really trying to get integration down to the practice size if we can. So it's hoped that PPGs at practices will give them a voice into that, as well as the PPGs which are going to be developed for the ICP as well. And what we have seen in the last 3-4 months is the really good patient engagement and volunteer support for the local PCN vaccination campaign, which has been a good marker for the relationships that PCNs and practices have had in the past, and I think is a really good indication about how well they can work together going forward.
Thank you. Councillor Healy, please.
Thank you, Chair. Quite a lot of what I was going to ask has already been answered, but I'm a little bit concerned about a couple of things. One of them is that the ICSs are being introduced and made statutory bodies before the legislation has gone through, which is a bit similar to what happened under the ill-fated Shaping Our Healthier Future, which was suddenly dropped by the government. So I'm a bit concerned about whether any of these things are going to go through. More specifically, I'm concerned about what is said about elective care. It's very good that the numbers waiting have been reduced by more or less half, or close to half. But what worries me is that there seems to be nowhere in the written statement of any chance of influencing decisions by either the patient or their families. Quite often it's not just clinical need that's important in making decisions about operations, it's the whole family situation, or indeed if there is no family. It does, I think, need a wider range of people being involved in the decisions that are made, not just doctors and nurses without really considering these items.
So certainly, so that's part of the counselling primary care is going to be given about how they can feed in those other factors which affect people's well-being. I mean, the reality is that there has been very little resource free and available to cope with the waiting lists up until this point, and now it's working incredibly hard. You know, consultants in hospitals are working incredibly hard after 18 months of dealing with COVID, now trying to catch up with the waiting list, which they are doing very well. With regard to the ICS becoming statutory before the white paper goes through, of course, we're not in control of that. We just have to wait and see what happens.
Thank you. Any more questions on this?
Yeah.
My vice chair, Councillor Addenbrooke, please.
Thank you, Chair. A couple of questions. Going back to mental health, you talk about an increase in young people with eating disorders. Have you also seen an increase in self-harm and other particular issues? And then the 14.4 million that you are going to spend, additional spend, could you give us some idea what that's going to be on? Then on vaccine hesitancy and uptake, I think we all really welcomed the mass vaccination within the borough last weekend. I understand it was very successful. Could you let us know if you plan to do more of that going forward? Because I think we're going to see more and more students coming back from university and children coming back from schools. So the vaccine bus, I think, is a great initiative, but I understand they only get a very limited number of vaccines per day. I think it's something like 27. The other issue is that I understand here we're not getting the Pfizer vaccine on the bus. Is that something that we could look at? And then I think there's still an issue around data and GP lists. I know at home that I get letters every now and again, probably once every few months, for people that haven't lived in my house for over 10 years, but must still be sitting on my local GP's list. So is there some work going on about cleansing those lists? Because I think you might get a clearer picture of who really is in the borough and needs vaccinating, rather than just sending letters out to people who don't exist anymore? Thank you.
Oops, sorry. Yes, so if I haven't got the detail of the CAMs, particularly what those particular areas of investment are. I do know there is a programme, and apologies that I haven't got that detail, but we can, I'm sure, come back to you on that. And the other piece of work that we are continuing to work on as a system with both our providers, our acute and our mental health providers, is also making sure when young people do access services that they are seen in the right part of the system as quickly as possible, because of the increase in activity, we've also seen young people being in acute settings longer than they perhaps ideally should be there, and we are really working collectively on that as well. But we'll come back, and that's one of the pieces of work that we are doing as a system. So I'll come back to you on that. Was the next question around Pfizer? You do that one.
So we had a very successful weekend this weekend. We vaccinated over 3,000 patients on Sunday, which was by far the biggest number in northwest London. So really hard work from a lot of your local GPs doing that. We have a sprint program organised between now and the 19th of July, when we've set ourselves and agreed with NHSE local targets on the number of vaccines per week. So last week we were supposed to have 100,000. We got very close with 96. We've got 112,000, I think, this week, going up to 147,000 on the week of the 12th of July, and then hopefully hitting the target before the 19th of July. So we are planning another Supermass Vax event at some point, probably along the lines of Twickenham or the Chelsea Football Ground, which we did before. But having said that, the most effective way of delivering vaccine to the local community has been through the local vaccination sites run by the GPs. So a lot of what we are doing is making sure that they get enough vaccine and support to deliver vaccine from those centres, which locally for us have been Violet Melchett. It was for a short time Earls Court Health and Wellbeing Centre, and of course St Charles as well, who did particularly well this weekend. Amazing work that they did. The supply of vaccine to the vaccine bus, you're absolutely right to say they get supply of vaccine during the day, and it comes in batches of 30 at a time. That's partly to make sure that no vaccine is wasted. The bus does vaccinate. Enormous variation in the number of people it vaccinates, but if they need more than 30, then they'll get it delivered in batches of 30 during the day. So if it's needed, they can get more vaccine going forward. The decision not to have Pfizer on the bus, which was a decision made by the head nurse of North West London and the head pharmacist, which was based on the inability for our particular bus to maintain the Pfizer vaccine properly, also the lack of space to monitor the patients after the vaccine. We were going through a particularly hot period of time at that time too, so it was difficult to keep the vaccine cool enough, and the increasing difficulty we had for that period of time too with safety and the rising number of anti-vaxxers. So the decision that was made for North West London was that the bus could certainly be used for AZ, but Pfizer would be better delivered from a building, and we're hoping that we can put the bus and the buildings together to make sure that we get the advantage of both. Was there another question? I can't remember. Sorry? Was there another question?
So, and just the last question, going back to the ICS, has the North West London ICS agreed on a financial delegation to the local ICP? And if so, what is the formula being used to allocate funding for local ICPs?
So the simple answer is no. Hasn't been any agreement yet. You'll see in the paper that it alludes to the fact that there was relatively recent guidance on the ICS framework was released on 16th of June. And within that, that was giving indication in terms of direction of travel and how much potential local ICS discretion could be used for that. So part of the work that is now ongoing is working through what a financial, within the North West London ICS, is what the financial delegation options could be, and then that will come and be decided at a system level in the coming few weeks and months. There's quite a lot still to be done, though. We've got the basic infrastructure in terms of building on the work that we have been doing as an ICS already. Again, alluded to the fact that it obviously does need to all be confirmed by legislation, but the direction of travel was certainly set out in that framework, so that's given us a little bit more ability to work through, and by autumn we will have certainly the sort of key leadership elements, and I would anticipate that the outline of the delegation would also be being considered and worked through and shared.
That's it? Okay. Thank you very much. Is there any more question from those who are present to follow up? Or there is one question from a committee member who could not attend. I will read it on his behalf. Councillor Spalding, he sent me this question. Regarding the report, with due respect, there is, he could not see an authorization, a person or a signatory to that report. We know the heading. So he said there is no author or date on that report. The other thing is, this is regarding this on procedure. So the operating cost he mentioned here on the Northwest London CCG and the new ICS, how could we have the numerical data, the comparison between the two set of data moving from one set to another, like the number of employees? You mentioned about the budget constraints and the changes, and the total salary cost and the number of patients served. So that's these various questions on that. So please.
I think the document is dated, but I appreciate it's just June 2021 as opposed to a specific date. From an authoring perspective, that it essentially is being approved by our ICS communications team, and Director of Communications would oversee that, and as I say, we'll feed back the comments on that. With regards to the running costs, I think it was I'm not going to be in a position to determine that in terms of comparison with the CCG and the ICS, but recognising it is a different function. So there will be differences and changes, but won't be able to determine that until we're clear about what the structure and final structure of the ICS will be. And I'm sure, again, that will be, there will be in the usual way for statutory organisations, that all information will all be made available. In terms of the population served, the whole of the North West London ICS will cover the 8 borough areas of North West London, and the registered populations of our practices, which, as you know, are not completely coterminous. But that would be the area of responsibility for the ICS. Was there another question in there about overall costs? I think it was, yeah. So within the costs within the ICS, or the expenditure and responsibility of the ICS, it will be the provider costs and for running the provider organisations, as well as the resources that we get as a system for commissioning, paying, organising, coordinating, less of a commissioning role now, because that's one of the changes that is happening going forward. But it's the same really as is now. The only thing I was just going to note is obviously the work that we have been doing as a CCG and moving to a single CCG, as Andrew alluded to earlier, has already realised some efficiencies and reduction in our running costs as a CCG, and that challenge around making sure that we have got the right workforce within the CCG moving forward into the ICS is also something that we are carrying on now, and there will be changes certainly in the senior leadership. Though the majority of the staff within the CCG, there will be a ongoing function and role that they will be required to fulfil in the new ICS.
And maybe what we could do is bring Stephen Bloomer, who's the Joint Chief Financial Officer, along at stage. He'd love to come, I'm sure. But the expectation is that as we move towards an ICS, there will be a 10% saving in certainly some of the clinical costs, clinical leadership costs, and other organisational costs as well. Now, whether that's actually achieved, we'll have to see. But that's certainly an idea of the scale of the ambition.
So that's specifically focused on the running costs as opposed to, clinical costs. Or...
Thank you very much. I mean, here just as well highlighting regarding the numerical data in the report. I mean, it will be nice and very informative to have that to hand, so our councillors and committee members can compare data and make constructive questioning and come to this term. Thank you very much for this interesting discussion there. And just want to highlight a little bit on the communication aspects. I mean, this one is really vital, especially still up to now for the pandemic, where we are seeing the lockdown and the uncertainty surrounding the 19th of July decision and the waiting and the behavior. How this is reflected, because there are some elements there of management. If we say logistically regarding the assignment of vaccine to different places, I mean, I can see the complexity of the operation. It's very unusual. We learned a lot. Moving now from 8 to a single integrated care system. And the impact on the mental health and the well-being of patients, how this is going to be addressed?
So I think it will happen in lots of different ways. I mean, what we have seen is that the delivery of vaccine locally has benefited enormously from bringing different providers together inside the NHS. So it has been a real fillip to the integrating process, and actually quite an exciting illustration of how integrated services can work really well together to deliver an enormous project. The biggest project the NHS has probably ever had has gone relatively smoothly. So I think that's very important. I think addressing population health is a project that we're all trying to do as well as we can going forward. So there will be a clinical strategy or a health strategy for the whole of North West London, which will have some very high-level outcomes that it will want to achieve, which will include mental health. But the biggest one, I think, which has already been signposted for the NHS, is how do you deal with the inequalities that are in the system and make sure that we learn the lessons, particularly of the impact of COVID on certain communities going forward. But we've had our own indications of that with North Kensington in the last few years as well. So there will be a strategy, a health strategy for North West London. The really exciting bit will be how we develop a local one with our ICP as well. And we've got members from the local authorities here in Westminster and RBKC that are joining with us on building a local health strategy too. So I think that could be really quite exciting. One of the things I think that different scrutiny committees might have to learn is you are partners of the healthcare system going forward. So you have a seat on the ICS as well as the Health and Care Partnership for North West London, and you also are one of the 4 partners in the local ICP too. So a lot of the data that you're asking for, you know, will be shared with you as a part of this ongoing relationship as we go forward. So I mean, hopefully that will lead to better communication and better relationships between health and social care going forward as well.
Thank you very much. Do you want to add anything, Leonard? Yeah. I think thanks for the reassurance, especially addressing inequality and the development of a strategy to address that specific issue. I'm really grateful to that reassurance from you for us to be involved earlier in the co-design and the formulation of that strategy. On this point, I think we can finish here for this discussion. It's a lot of things being said from addressing the various issues on improvement, addressing the deficits, as we finished off on regarding the inequality standard, and the community needs, patients being at the center, local vaccination to be for local practices to learn the lesson from the vaccine, and the logistics. We acknowledge the complexity of this operation, and we really thank you as well for, I mean, having myself the second jab. I was one of those hesitant to take the vaccine, and I've taken it, and I really congratulate St. Charles when I had it. It was very smooth operation, and as an operation manager and practitioner, I really salute their smoothness in terms of managing those complexity in terms of giving our residents an assurance for their health and well-being. So I really thank you, and thank you for joining us on this item to enlighten us and take the questions from our committee members and our councillors and co-optees. So thank you very much. You are welcome to stay for this next item if you wish, or you are welcome to leave as you wish. So, yes.
I just wondered, Chair, whether there was any possibility. I know there's the primary. Whether you were wanting any response on the primary care paper, and whether
So you can, yeah.
and whether or not it was possible just to maybe take that now.
Yes, this is my next item.
Oh, is it? Okay, that's
Yeah.
really helpful. Thank you.
So, as well, yeah. So now I move on to the A6 item on the update on the mental health urgent and acute provision. So let me take the A7, isn't it? We take
Yeah,
straight?
take. We're going to take.
No, yeah. Yes, yeah, we'll do that. So we can take A7 first, then we move to A6. Yeah, we'll skip one item. Yeah, I do apologize. Yeah, mixed up there. Okay. So, so this report will go to item A7 on the primary care working group recommendations. So this report sets a recommendation made as a result of the work conducted by the primary care working group. And the working group made a certain recommendation where the center of it was really the digital communication, the different channels for virtual consultation, patient participation, the population needs in addressing their health and well-being, and the development of the primary care networks. So now I will take that report as being read by the member, and I will ask the primary care lead to just brief us, if you would like, Christine, on the working group with you and Councillor Thexter, and then we can go for questions.
Thank you. I was a member of this group, which was led by Councillor Thaxter, who had to send her apologies this evening, so I'm just going to present the paper. This arose out of concern from residents about access to primary care, which is still an ongoing issue from the recent workshop that we had. We had a very useful meeting, and I wanted to thank the clinical directors of the PCNs in particular for coming to that meeting and contributing so fully to it, because I think that was really useful. Out of that meeting, but also out of the evidence that we heard as a result of two calls for evidence, one to patients and one to primary care providers, we have come up with these recommendations. We have already had some response from the CCG, but I think at the moment that the process would be for the committee to look at these recommendations and agree, disagree, or add to them, and for us then to send that through and ask for a formal response in a couple of months' time. So you have the recommendations in front of you. They center around the use of digital technology, the reactivation of the patient participation groups, and importantly, as we've already discussed a little bit this evening, the role of the PCNs in developing a strategy around population health and preventative work, which was something that came out of the call for evidence, and also more information being available on the role of PCNs as they develop. So I'd be very happy to have any thoughts or comments from members of the committee on these recommendations.
Yeah, thank you, Christine. I think the recommendation being circulated, you all seen the recommendation? Okay, Councillor Woodger, please.
Thank you, Chair. My question as, I suppose, one of the more youthful members of this committee, what's the definition of young people? They mentioned young people know very little how to navigate the health system. I'd argue quite a lot of people in general know not a huge amount about how to navigate the health system. I mean, what was your definition with working with that? And obviously, in terms of consultations, I agree digital consultations doing more of that is a really good idea, but we mustn't forget that not everyone has access to smartphones, to technology, so we do need to keep some of the paper stuff as well for people who don't have that type of communication.
Do you want just to give some assurance there? Sorry? Dr. Steedham?
Christine, are you wanting to take those initial... Yeah.
I think that, I don't know what the young people refers to. I mean, if it was out of the Health Watch report, which was considered at that meeting, there would be young people between 18 and 24, but it may be more general.
Councillor Williams.
Yes, if I can sort of just make a comment about this. In a previous working group, which I think for various reasons never actually made a formal report, we did come across this issue, and I think the problem was that there were people who were regular users of the primary care services, and they knew their way around the system very well. But those who were not, and I think it was the young and perhaps in some cases the not so young, sometimes found this a bit difficult, and therefore I think the PCNs need to think about this and how they can help people as they are not really very familiar with the system.
Okay, thank you. Christine.
So is that something you would want added to the... Yeah, it's just a comment. Yeah, okay.
I think for these four main themes recommendations, and we had the response from CNWL, CCG, I think for us, we can adopt them, and we'll study the responses, and then we can come up with a further decision for September. We need, so I think it's appropriate to improve on some of those definitions, because we need to be in line with the what's the rest of the definitions to be consistent in terms of producing. There will be a lot of terminology now emerging, and during this work, I've never seen more terminologies and standardization in terms of knowing where to define certain terms. So these can be addressed as well. And in principle, I recommend to this committee to accept these recommendations for the being and to be looked into in line of the responses we had from the NWL, CCG.
Thank you, Chair. I mean, I think it would be useful to review in September, because this is all work that's ongoing, and very much realise that things alter. They've altered even since we had the last meeting. So that would be useful. Thank you, Chair.
Okay, thank you very much. Do you have anything there to add in addition to...
No, nothing other than noting your point about the jargon or the...
It's not jargon, I won't say. I mean, there are
acronyms being used, so we
more
will
or
make...
less terminology where that's need to be really clarified, especially in terms of an integrated system, because in databases and development of databases, you really need to standardize the terminology in the data, because if we are looking at quality data, believe me, that's going to be even worse, because computers, systems, they need to be a very clear set of terminology assigned. So hopefully later on, when you produce reports, the quality of data has to be top priority. From my involvement in data system development is critical. But thank you very much for accepting that. So on this, thank you so much for Christine and Councillor Thaxter for producing this work and the acknowledgement that this is work in progress. Hopefully we'll come back to it again in September. We'll have more progress on that integrated system, which I'm really interested to see formulated. Thank you for joining us for tonight. And very good evening. You're welcome to leave. So here we finish the item A7 on this care, and sorry about the introducing. Now, who's going to go back? Okay. Thank you for bearing with us this little hiccup, and we go back to the item A6 on the agenda, and this is the CNWL update on Kensington Chelsea mental health urgent and acute provisions and flow. We have an update from CNWL on mental health acute patient provision for our BKC residents. including patient activity, access, challenges, and mitigations. Now, if members agree, I will take the report as read, and I understand that Anne Sheridan from the Borough Director, CNWL, she is here with us. Thank you so much for joining us, to answer your questions. So I will take the questions first from members of the committee, and then followed by councillors attending in the public. Now, do members of the committee have any questions? We start with the Vice Chair. Councillor Addenbrooke, please.
Thank you, Chair. Thank you for this report. I think it gives us a really good idea of what is working well. But are there any areas that you're particularly concerned about? I mean, for me, there's one area that we discussed earlier in the previous report about children and young people and the increase in demand there. So what are you doing to address the issue of children, young people transitioning into adult services, where we know that the thresholds are very, very different? So I think that's a really important area, and I think that's missing from this report. The other thing is that following the closure of the Gordon Hospital last year, have you done a COVID impact assessment? And how confident are you that the bed capacity will be sufficient for the increase in demand following the lockdown? Thank you.
Thank you. So yes, I'm Anne Sheridan and I'm the Borough Director, and I'd like to introduce my colleague Yasna, who's the Clinical Director, who's working alongside me and who will be supporting me with the questions as well. So apologies, the paper doesn't address children because I hold responsibility for the adult services, but in terms of the transitions, we actually work very closely with our children's services in CNWL, and we have a committee that actually looks at transitions, and certainly for those young people, we work very closely and indeed are able to provide services for 17 onwards in our acute adult wards, and we've done a lot of work around making sure that we have the right environment and also the right skill mix in supporting those young people. Obviously, in terms of children, CNWL has a provision which provides children's services, and I can certainly take it back and get my colleagues who lead on the children's services to provide a paper and talk a little bit more. It is true that as a result of COVID, we have seen an increase in children accessing mental health services. That's very clear to us. And also we have seen an increase in adults accessing services as well. I think in terms of the COVID impact around the Gordon, I mean, obviously the Gordon is a temporary measure at the moment, and there will be a consultation to look at that. We certainly have been working very closely across Kensington, Chelsea and Westminster to ensure that we are in a good position to sort of manage our beds effectively. And I think this paper does show that we have been doing pretty well in that area. And certainly we have looked at a number of support services around people who are in crisis, recognising that not everyone needs to come into hospital or needs to stay in hospital for long periods of time. But what I am very clear about, anyone who needs a bed will definitely get a bed, and that we're very clear about that. So I think the paper does demonstrate a number of support services in terms of step-down beds, and certainly post the temporary closure of the Gordon Hospital, we have introduced extra step-down beds into our system to support those people who are thought to be clinically ready to leave hospital. But obviously from a mental health perspective, we also support that wider holistic support for people and helping them feel ready to move back into the community. So our step-down provision supports people around engaging back in with activities, employment, housing, etc. And that has been something that has been in addition to what we had before the temporary closure of the Gordon. Does that answer your questions?
Thank you, Anne. Councillor Williams, please.
Thank you very much, Chair. Firstly, can I sort of congratulate you on the a very good figure for 30-day readmissions. I mean, that is something I think is a real achievement. And I remain concerned, as now have been for some time, about the placements of people in bed when they need to be a bed away from the borough, which in practice means away from other than in St Charles, where a third of our residents requiring beds are not going to St Charles, because even Park Royal is not that accessible if relatives need to visit them. And in some cases admit it's further afield. And I just ask that this is something we continue to monitor and report to this committee, and I know you are trying to reduce that. The other question was that I think an issue we've been concerned about before this committee has been people who remain longer than is strictly necessary. They shouldn't be there at all if they need to be admitted to a mental health facility in a police cell. Do we have statistics on that, and what has been the trend recently?
So in terms of ensuring that we admit as many people to St Charles as is possible who are residents of the borough, we have a central bed management system where all requests for beds come into that system, and we look at it, and I'm very clear as the borough director that we certainly prioritise those people who are known to services and have connections, and we try and place people who perhaps it's their first presentation, or they are foreign nationals, or people who don't have the same connection to St Charles in the Brent services or in the Northwick Park services. But what I can tell you is that everyone that is placed outside of St Charles, we have a home treatment team that quickly links in with those people and actually works to ensure that those people's needs are met and that they're not forgotten about, and that we ensure that they're kept as part of our discussions around all of our patients at St Charles. So in terms of that, that's one of the things we did. And sorry, I've forgotten your other question.
People being kept in police cells.
Yes.
Yeah.
I don't have the figures in this paper, but I can certainly get them. But I can tell you that obviously once somebody is in a police cell, unless a crime is being committed, obviously there is a different route and people do have to stay a little bit longer. But for those people who actually need to come into hospital, we very quickly facilitate that. And I'm involved in daily calls, even at the weekends, and where we have people in our police custody, we will endeavour to bring those people into St Charles, and possibly through the 136 or the use of the Mental Health Act, we'll bring them to our health-based place of safety. So at St Charles, in addition to our inpatient wards, we have 3 health-based places of safety. That's for patients who come into contact with the police and where we can quickly assess the patient. So we try and ensure that people don't spend long periods of time in custody. And although I haven't got the figures in front of me, I know that for Kensington and Chelsea, that isn't something that we have people staying long time in cells, because we work very closely with the police, and we're very fortunate to have a member of the police who works with our team at St Charles. So that has really promoted really good communication and thinking around how we work more closely together. But I can certainly get those figures for you.
Chairman, could I just ask that, say, in 6 months' time, in December, that we request from, and this goes down as an action from CNWR, an update on the statistics on readmission rates, out-of-borough placements, and indeed the people being detained in police cells, if that's possible. But certainly the other two, could that go down?
Yes, I think that's a reasonable request. And Councillor Atkinson, then Councillor Woodger, please.
Very good. I'd like to say it's a very good paper. I particularly like the fact that it's got figures in it, and can I encourage you to carry on doing that, and I will certainly keep this, and then we can make some comparisons when we talk to you again. Secondly, I mean, I am interested, I think it's very sensible, the idea of step-down beds, which I think is a good initiative, and I just hope that you have sufficient beds to meet the need. I'm interested in item 4, reablement team, which again I think is a good idea apart from the name, which I think is appalling. When you say mobilising, you mean it's in the process of being introduced. I'd like to know the size of this team, and is it envisaged, just how many people do you think you will be working in the team?
So you're right, it's just been set up, and we're working very closely with our colleagues in the borough to set this up. My understanding is that it's going to be made up of social workers and support staff, and I think we're looking at a team of no more than 10, and I'm looking at Chanel because I know she's been working very closely with us on this. So it's to complement our community access service. So we've got a community access service already based at St. Charles, which is really working in a holistic way around people's needs, and this extra funding, which is working very closely with RBKC, will complement that. And my understanding is it's a mixture of support and social care staff to really embed the social care element into the wider health support that we need.
Yes,
Thank
follow
you.
up.
I mean, that is precisely why I think it's such a good idea. Did you actually say you've got additional funding for it?
Yes, I'm looking
From
at,
where?
I think it's from our long-term plan and supporting early discharge out of hospital. Additional funding was found, and we were very keen to actually I suppose, enhance the service we already have, but from a more sort of social care element, recognising the work that's done in adult social care around supporting people when they leave hospital and really helping people to sustain that, because we know that when many people leave hospital, it's quite a vulnerable time for them, and certainly the work that social care has done has been very effective with other client groups, and we've felt that perhaps mental health service users have missed out a little bit, so this is really to enhance that offer, and we're really quite excited about it.
Chanel, please, any comment on this? Thank you.
Yes, my name is Chanel Arcud. I'm the Director of Health Partnerships in Adult Social Care. CNWL has offered us £300,000 for this year funding from their winter plans funding to develop a reablement for mental health patients offer. We currently have reablement in-house service for our older adults and physical disabilities population. We do offer some reablement for people with mental health conditions, but we haven't got a specific offer or well-trained staff on mental health. And this will be an enhanced offer. We're in the process of working with our commissioners to actually commission it. It's not in place yet. The offer will be to enrich to the hospitals when patients are nearing discharge, to work with them to discharge them from the wards into the community, settle them back into the community, and follow up and support them for about 6 months, up to 6 months, make sure that they don't relapse and they don't end back in to hospital again. That's the ambition. We will start with a small number of care workers, and this is across the 2 boroughs. The ambition is also to build it in our reablement offer in the long term.
Talking about joining up the services that are provided, and this seems to be a very good example of it. And can I ask that we get a report on progress in the future? It's something that really interests me. Thank you.
Yeah, thank you very much for this comment, especially as Councillor Atkins said, it will be good to reflect on the joint aspects of this work. It can be highlighted so we can see for future comparisons. Councillor Woodger, please.
Thank you, Chair. I can see length of stay has reduced from 36 days on average in a year to 31 days, which is good. I'm just wondering, in the wider context, how does that compare to other areas? And what's the target to reduce it even more?
Thank you. Well, what I can say is that actually we did a lot of work around this because we were a little bit higher a year previous to this, and I think that we are around average in comparison to the other boroughs within C&WL. They might be a little bit lower, 28 days, and we continue to do a lot of work, and I think the describing the CAS team, the community access team, where they're working to really address people's needs once somebody is admitted into hospital. So I think what is different now and what we'll be building on, that when somebody comes into hospital, we very quickly work alongside them, put around an enhanced offer of care and identify quite early on a discharge date with that person, their family and their community. And this has really helped focus us with the patient and their wider network around thinking what needs to be done when somebody is sort of moving through that journey to be discharged. And that has really helped. And we have found actually really focusing on some of the key issues around what brings somebody into hospital, but also perhaps what some of the issues are that maybe will slow somebody down leaving hospital, because in mental health one of the key challenges is thinking about the whole person. Now, obviously I appreciate that's for everyone, but certainly for mental health users, often by the time people come into hospital they may have issues with their housing, their family, their employment, and so actually addressing all of those alongside their mental health issues is really important. But I think we probably would be looking to try to get it to 25 days, but everybody's very different and very unique. But I think that's where we'd be aiming for. Just looking at you, Yasna, isn't that correct? What I'd like to add at this stage is I think one of the reasons that we have been able to do this work in RBKC is that we already have a very strong relationship with our partners, including our local authority. So I know I've got Tim sitting behind me, who's the lead social worker in mental health, and we have weekly meetings where we look around supporting people to be discharged, and certainly looking at some of the challenges that perhaps somebody's experiencing. And that has worked very well for us as a borough within C&WL and how we've managed our urgent care pathway.
Just to follow up.
Thank you.
If 31 is the average, in the more difficult cases, I suppose, what's the upper end of that, would you say?
Who are in hospital for 90 days plus, and we've got 3 people who are in hospital 60 days plus, but actually that is very good in comparison to other areas of the trust. And those people are often in hospital because we are maybe looking for complex placements, and just getting that person's step up into more intensive support can take a little bit of time. Certainly something we're looking at is actually thinking around not just identifying one option for somebody, but actually now coming to the table with a number of options, because it may be that actually getting a placement isn't that easy, or perhaps isn't that suitable. So we've been looking at enhanced support around somebody going back into the community. And in some cases, people's mental health takes quite a long time to sort out, and people may be tried on different therapies and different treatments as well. So yeah, we've got 3 people 90 plus and 3 people 60 plus days currently for RBKC.
Thank you, and is that okay, Councillor Roger? All right, Christine, please.
Thank you. 2 questions. You talk about the liaison service at Chelsea Westminster. You don't say anything about an equivalent service at St Mary's. And Imperial used to report regularly on trolley waits, people waiting for mental health beds. So I'm wondering, could you just update us on that situation? Are you still getting that pressure from St Mary's? Does it have an effect on your bed availability or your assessment team availability? And then I've got another question, but it's quite different. Shall I give it to you now? Which is around the newer alternatives that have been developed. I mean, you don't say anything here about any service user or patient involvement in that. I think there has been some, so it would be very useful to have that. I mean, I think anything that is proposing a redesign of services ought to include something around patient and service user involvement and what's been learnt about that. And I know there was disappointment that there wasn't any or much around the coves when it first started, which may have been partly because of the pandemic, but it would be useful now to know going forward what your plans are.
Thank you. In terms of our liaison services, you're absolutely correct. We have a liaison service at St Mary's as well as Chelsea and Westminster. And I think because this paper was looking at RBKC, we focused more on our Chelsea and Westminster service. I mean, the liaison services work very closely with A&E colleagues to support and think what is the best outcome for somebody who comes into hospital with mental health issues. And indeed, some of that work, certainly the work we've talked about around the Red Cross, has led to people actually moving through our A&E services quicker and actually supporting people leaving A&E much quicker than we would have expected previously. Obviously, we have 2 calls every day where we monitor people waiting in our A&Es very closely. And yes, there is demand from both A&E departments, but very appropriately and rightly so, because obviously A&Es aren't the right place for somebody who's got a mental health crisis, and we need to be working very closely to get somebody into hospital. I mean, I was on call this weekend and we had somebody who was a young woman who was pregnant in St Mary's, and we worked very closely to ensure over the weekend that lady moved into a bed at St Charles. So yes, we are working very closely with our A&E colleagues, and I have to say that certainly for Chelsea and Westminster, I think we've had 3 to 4 breaches over the last year. The number given here obviously reflects people who come into Chelsea and Westminster and that are not RBKC resident, and actually they may have connections with other trusts or other parts of the country, and we work also to facilitate those people to be appropriately placed back into their own areas. And in terms of patient involvement, everything that we do in terms of the different opportunities and different provisions we have identified here will have involved a patient and carer and indeed wider communities, and some of the work will also have been co-produced. You're absolutely right, the COVES didn't have as much service user and carer involvement than we would have liked, and definitely the pandemic did play into that, but certainly we have learned lessons, and moving forward we will always ensure that people are involved, and also receiving feedback, because not only about sort of setting up services but actually finding out how effective the service is. So we work very closely with our Health Watch and other colleagues to receive that feedback, and our meetings will have service user and carer voices in them, giving us real feedback.
Thank you, Anne. Any more questions? No? Sarah, you want to follow up on your case? No? Okay, it's finished. Okay. Yes, Councillor Round, please.
Thank you. Sorry if I missed it, because apologies for being late, but I noticed there's no mention of waiting times in the report. I just wondered whether you could give an overview of waiting times experienced by patients. And also, if there was one thing that you would want us councillors to take away tonight on this topic, especially you, Tim, what would that be?
I mean, I think we're very fortunate in RBKC that our waiting times are actually less than 12 hours. So I think, as I said, we have had 3 to 4 breaches in the last year. And it's something we monitor very closely. But it's something that is a constant. So this evening, I know we've had people in A&E and we will be working. So certainly if somebody is over 12 hours, that becomes a breach. So certainly we work in trying to ensure that nobody is more than 12 hours, and actually is a lot less. And as I was saying earlier on, as well as our bedded provision at St Charles, we have 3 health-based place of safety rooms where we can take people to be assessed who are being brought in under the 136 part of the Mental Health Act by police. So there's that facility as well to take people out of A&E much quicker. And also we have an assessment lounge provision at St Charles to support people who are not detained under the Mental Health Act, and that has all really helped us manage our waiting times. So at the moment, it's something that isn't an issue for us, but it's something we're constantly monitoring. And I guess as we move out of COVID, we are, we believe that we may see more people needing to come into hospital, so that's something we will monitor very closely. And what would I like your support with? I think we would like to, and we are working with our local authority colleagues to look at step-down beds within the borough. So currently our step-down beds are within Westminster and in South London, and it would be really nice to work and have step-down beds locally in the borough of Kensington and Chelsea. But as I said, we are working very closely with our local authority colleagues around the commissioned housing services to see how we can facilitate that. But I am pleased to say that our coves are in the borough, and I think we're looking to try and see if we can extend some of the timing of our coves as well. But yes, my ask would be if we were able to access step-down provision within the borough. Thank you.
Okay.
It is, yes. I'm Tim Gorvett. I'm
You don't have to speak, but I just thought a first-hand experience would be really interesting.
No, happy to do so. My name's Tim Gorvett. I'm the Royal Borough Mental Health Social Care Lead, and I'm responsible for the AMP Duty Service Mental Health Act assessments as well as the social care budget. I suppose I would, the one thing I think it would be important for us to explain, I think, is just how, in some ways, just how radical some of the things we're doing at the moment are. This question of patients spending too long on the wards, this idea that problems get resolved in series rather than all at the same time so that people are ready to move out of hospital. This isn't a particular CNWL thing. It's been going on for my whole social work career, 2 decades. And this is the first time I think we're really seeing an attempt to get to grips with that. And it's from the start to the finish. It's from trying to manage unnecessary admissions at the beginning with a more rapid response and a more sufficing response, all the way through to making sure things are done on the ward when they can be, to discharge at the other end being a safe and smooth, a rapid process. It's about bringing mental health patients into line with the kind of services that other patients get, and beginning just groping our way towards that thing about parity between physical and mental health. And that's what the reablement service is about. That's what the whole idea that people should have this really straightforward, safe, smooth step down back into the community or into an appropriate setting, even a discharge to assess setting, dare I say, which is what some of these step down arrangements are. So I would just say, hold us to account in a year or two's time to see how we're getting on with this and how this is creating also a smoother process for those coming in under compulsion at the beginning of a hospital stay. Quick access to beds there. Thanks.
I would just like to offer the opportunity. I know councillor colleagues have come, but please feel free to come and visit our services at St Charles. We've done a lot of work to really improve the environment, and we've done a lot of co-produced work. We have the One Community, which is a user-led service at St Charles to support a diversity of activities, and we have a number of third sector services feeding into that, so really working around gardening projects, reading projects, beautiful people. So there's lots of lovely things happening to actually, yes, make it an experience. Nobody wants to come into hospital, but when people do want to come in, we want to ensure it's an empowering experience and that people have a voice. So I would really welcome you to come and yes, give us your feedback. We'd really welcome that. Thank you.
Thank you very much. We welcome, hopefully, when it's time right, we'll set a few visits. It's nice as well to see the patient trail, because now the trend in the whole system of patient treatment, the pressure on the budget, and at the same time aiming for good quality outcome. This is a big challenge for any management. So hopefully that system and that smoothness in the processes to be clearly laid out, and hopefully will get some more inputs into future regarding patient trail into the system. And what I would like to see, hopefully, how the pandemic, from your data, previous data, how the pandemic really affected the stages now we are in addressing mental health. So that's hopefully that will be maybe a useful comparison as well, because the pandemic effects is not going to have to be completely diluted or gone away. Its effect is going to remain maybe for, we don't know, the number of years. So that's need to be closely monitored, and a clear dimension on the data quality as well, as we discussed earlier. But thank you very much. I mean, the report is quite good. A lot of work gone into it, and we are grateful for sharing it with us in its fullness. And you've taken our questions to heart, and thank you. So we conclude this item. I think there's no more question here. Just to add a little bit before we finalize on this one, is I've learned there is a platform being developed on an integrated system somehow to improve the level of engagement. Hopefully that will be included later on for our committee to look at, and with the other stakeholders you are involving with. So to conclude this item, I thank you again for coming to present this paper to us. So now we move to item where we need a lot of help from our officers. Item A8 for the work program. Did I miss something here in the printout? Yeah. So we are Item A8, the Select Committee work program. And this is our final agenda item on this in this evening. The Select Committee is currently in the process of shortlisting topics for the current municipal year. So I would like to call on our scrutiny manager, Jackie Hurt, to enlighten us on this exercise, and hopefully by the end of this meeting we'll reflect on the best way forward in taking this challenge on optimizing what's been discussed in the workshop on the 7th of June. So over to you, Jackie.
Thank you, Chairman. So the report provides information about development of the committee's work programme between now and the end of the municipal year in May. Following this discussion, Councillor Al-Naji, as chair of this committee, will take a formal proposal to the Overview and Scrutiny Committee on the 8th of July, setting out what the committee proposes to scrutinise. So, by way of background, we started this process by asking for suggestions from the work programme from lots of different people, our councillors, residents, partner organisations and also staff who deliver the services. Those suggestions were put into a long list, and councillors met virtually on the 7th of June at a workshop to discuss and refine that long list to think about what scrutiny could best look at in this committee over the next year. So the criteria are based on the statutory guidance, which emphasises that it's important for scrutiny to prioritise, because there's so many things that we could do, but to prioritise what scrutiny should look at. So looking at where can scrutiny add value, where's the space for scrutiny so there isn't duplication, and of course what things are most important for our residents, so that at the end of the year scrutiny can have produced a work programme that does have impact and has tangible outcomes. So the suggestions from that workshop, the long list was made into a shorter list, which is in the report at paragraph 3.9 for councillors to further discuss. In thinking about that list, I should say that there are a couple of things already on the work programme. So the council has made a commitment that every scrutiny committee will look at a topic related to the Grenfell recovery strategy. Usually the committee looks at safeguarding for adults in the autumn, and there is a working group on mental health in North Kensington, and councillors Williams and Atkinson are at this meeting, and they've been leading on that work with Councillor Idris. So really the aim at this meeting is to have a discussion to refine that list of topics, and what you might want to do is decide the top few that you think you can scrutinise and maybe have a reserve list, and possibly consider how you will carry out the scrutiny. So we've had themed meetings, working groups, and we may also be able to arrange visits for the committees to go out if circumstances change with the lockdown. So that's all I have to say in introduction. Thank you, Chair.
Thank you. Thank you, Jackie, for this facilitating this work as well. It's as you can see, the discussion it has to be centered when we come to the two feasible topics to discuss. These two standards on the safeguarding and the Grenfell recovery related issues that will be standard on our discussion. Please bear in mind that we need the decision or the discussion. Now, they don't have to make the final decision if you like, as long as we have a good discussion around these topics in particular, bearing in mind that the year is going to be short. And the ongoing work program on mental health in North Kensington in particular, and then you can widen it, so it depends on the working group how they progress there, considering their capacity. So I propose that the task today is to further the priorities, refine the four pre-selected topics, and propose two topics only, if possible, out of these four, which we will find to form our work program. So I will leave it to you for further discussion, and so who's going to start the conversation there? Councillor Williams.
Yes, other than confirming that we hope the mental health group will really get down to work in September. In terms of the topics listed in 3.9, I mean, I think that some of them can be dealt with by simply bringing papers to this committee, and in particular home care service. In asking that that be considered, did not envisage that we would have a working group on it, but we need to monitor the performance and the challenges faced by home care, which is, we certainly in the past when Councillor Addenbrooke chaired the committee, and I was for a while was the leadership team member. This was something that we did focus on often in a Part B discussion. So I mean that is it isn't going to take much in the way of scrutiny resources either by members or Mrs. Hurd's team, and I would recommend that one remains and is done in that way. And again, public health budgets and outcomes. This needs probably one report in the budget preparation season, because this council has a large public health reserve, and I think the way that is the budget is used and what's happening to the reserve is something that should be scrutinised. Again, it doesn't need a working group, it needs a report to this committee.
Thank you, Councillor Williams. So that's any other comment on the other recommended topics? Councillor Atkinson, please.
Councillor Williams, I think that these are the two areas he's identified are very important and ongoing important, and I would recommend that we take them as reports coming to us so we can monitor them and look at them more than just once. I'd also like to say that I think another way in which we can do our scrutiny job well would be to have a regular item and attendance from the lead member. And I notice that I think we're pushing it an open door there. I would like a regular attendance from the lead member with a written report, both to tell us what they're working on, particularly looking at upcoming key decisions, and also, secondly, to ask the lead member what they're worried about, what is concerning them, because I think that's an important part of scrutiny, and I think that would allow us to take on a number of questions. And as I say, I think the lead member has indicated that they will be prepared to attend regularly.
Thank you, Councillor Atkinson. I think in terms of our work and to be aligned with the Council's strategy, your proposal there is valid and is critical to the progress of good scrutiny. Councillor Edinburgh, please.
Thank you, Chair. I agree with Councillor Williams and Councillor Atkinson on all the points they've raised. For me, and I know I'm going to sound like a broken record, but I still think transitions for people with mental health and special educational needs is so important, particularly now more than ever, I think, as hopefully we do come out of COVID, and I'm really disappointed that it's not in this list. So I don't know whether everybody could reconsider, or we could all reconsider, but it really is a really important area, and I think we and our health partners could do better.
This is something to consider, certainly. I'm surprised not there, to be honest, during our discussion. I fully agree. But this is what's happened. We can, if the committee feel that need to be included, I'm happy, because that's an area misunderstood. Especially that transition stage is between young and adults, and then with the pandemic, with the loss of a lot of opportunities, I think we are happy to take that point, Councillor Edinburgh, and maybe Councillor Atkinson, and as well Councillor Williams.
I just say, could I, through you, ask Councillor Edinburgh what form she thought we should address this, through a working group or a one-off report or a half-day seminar or what?
So that's a good question. I don't think a one-off report would be good enough. I think we've got to go much more in depth into this, inviting in partners, full of life, people that are living this. I know Councillor Rossi has suggested to me about talking to the schools, the hospital schools, because they have a big issue there with children who are in hospital, may never leave or leave some, at some point, but they hit 18 and it's a completely different system. So I think, I don't know whether it's a workshop or whether it would be, whether we would just invite lots of people in and have a seminar. I don't know, but I think it's an area we really do need to look at.
Well, I'd just suggest going through you this, I know it's of particular interest to Councillor Addenbrooke, perhaps she could come up with some ideas about how we take this forward, because as I say, I'm not there myself.
I think that the proposal, Councillor Addenbrooke, it can be the basis for a joint work with the Family and Children Services scrutiny. So we can, Councillor Rossi.
Yeah, if I can make a comment. I mean, the recommendation is that we have shorter agendas. We have, say, at maximum 2 or 3 items on agenda, which means that if you do get a report, that you could sort of spend quite a substantial amount of time discussing one topic. The other way you could go would be to have a single issue meeting or a themed meeting. That's another way of looking at something in depth. As far as Family and Children's Services is concerned, I think they've set what they want to do, so you would have to ask them if they were minded to do that. But I think that there are other ways, or having a working group in this committee and some kind of liaison between the 2 committees might work. Okay.
Yeah, thank you, Councillor Rossi. I think, we don't want to impose any work on already set work program for another scrutiny committee, but here is coming from one area into the adult social care domain, so we can look specifically at that transition and make, if you feel strongly as a committee members, in addition to the other topics there, as Councillor Rossi, we need to focus on at least 2 topics. Councillor Atkinson.
I'd like to start by agreeing with Councillor Addenbrooke. I think that it should be on this list. And can I propose to knock one of these out? But, I do think the whole issue of vaccine hesitancy has been addressed elsewhere, and I think there's very little that we could add to that. And health inequalities we've dealt with previously. I think we're knowledgeable about health inequalities. So I would like to propose that we don't consider that and we put Councillor Addenbrooke's proposal in its place.
Councillor Woodger, please.
Thank you, Chair. This obviously exercise is cutting down the number of topics to work on. As important as it is, I actually think, realistically speaking, given the pandemic and everything that's happened, the health impact on air pollution at this stage is probably, it's harder to scrutinise because car usage has obviously gone down. So as much as I'd like to scrutinise that, I don't think the data would be that useful right now to focus on. So I'd probably knock that one out, but have it on the back burner to look at in a year or so.
Gareth, please.
Thank you, Chair. Evening, Councillor. My name is Gareth Wall. I'm the Director of Integrated Commissioning for Adults and Public Health. I just wanted to raise a kind of suggestion in relation to the discussion about home care as an item, if I could. I absolutely agree. Bringing a regular report on how the market is operating and some of the risks associated with that and how we're managing it would be really welcome from our perspective to get your input onto that. I'm also mindful of the point in 2.3 of your report about the policy development and pre-decision scrutiny role of the committee. And during the course of this municipal year, as a commissioning function, we'll be going through a process of recommissioning the way in which home care operates in the borough. And at present, that's on a patch basis. Geographically, that makes lots of sense. It's the way a lot of places operate. We also have some spot purchasing, like most places do, where capacity isn't available. But we're working with Oxford Brookes, with ADAS and some other local authorities to look at what different models of working with the home care market might be and how to stimulate different types of home care market locally, including through the use of direct payments, micro-commissioning, and encouraging that kind of further degree of personalisation. So that as well as those regular reports to the committee, there may be opportunities for members to participate in some of that policy development work as we hold workshops with groups like Oxford Brookes, etc., so that you can feed in at the earlier stage, whilst you might also want to sort of keep your powder dry for asking us questions about it afterwards as well.
Chairman, I would very much welcome that, because this is part of the pre-decision scrutiny. So I'd warmly welcome that to be included.
Thank you, Gareth, for that contribution. It's really, you can see it has a positive feedback there. And certainly, at the early stages of this pandemic, we lost many loved ones in home cares earlier. And especially the management, and as you highlighted, looking back and all these provisions in care homes and how this is progressed, I think will add value to include it in our work program. So I think we can put that item to the vote with the committee. I'm really in favor of that input and the recommendation. All in agreement for home care services item to be really an item to be pursued for the work program. Yep, I can see a lot of heads nodding there, so that's it. One item. Agreed, thank you, Gareth. It's really useful. Councillor Round, please.
Can I just...
And then Councillor Addenbrooke. Oh, I beg your pardon.
Thank you, sir. I just wanted to get on record, but I'm afraid I don't agree with my fellow councillor on air pollution. I think, actually, as the CEO of AstraZeneca recently said, climate change is a public health emergency, but one for which there is no vaccine. And I think we shouldn't drop our eyes on the ball of another very important issue facing us, whilst obviously dealing with another very important one. So I just wanted to put that on the record.
Thank you.
Sorry, just to respond. I didn't say it wasn't important. I just said there isn't going to be enough data given what's happened with the pandemic. To clarify my point, Chair.
You talked about cars, yes, but air pollution, it goes well beyond car usage, as the data does show in this borough.
This exercise is to try and find scrutiny. This exercise is to limit the number of topics. All these topics are important. But the skill of this is to find subjects which we can actually productively find solutions for and things that we can scrutinise and affect positive change. Environment is very important, and I'm on the Environment Select Committee, which I'm very pleased to work on. But I'm just being realistic with the limited amount of resources members we have. It's something we should put on our, I guess, secondary list, and we would come back to in future. But unfortunately, we have to make difficult decisions of what to scrutinise.
I mean, I'd support Councillor Woodger. I mean, as you remind us frequently, because of the elections next year, effectively, we've got a pretty short time scale. And this is a topic which I think would need a fairly extensive research. So it doesn't fit well at the present time, sadly.
So we spoke on all of them so far. There is one topic, as you said there. So I think we need the help of Jackie here, if I call on you regarding the time scale and what's feasible. May I suggest that maybe we can, like for example now we agreed on the home care, this is one definite. And then we can come back and select the second one as in that priority. And then we have another waiting list, as you say, a provisional list. If we are in agreement, we don't have to come, I'm happy that we agreed on one at the moment, so we can move forward with that. And the working group on mental health is going on, and that's prominent. Yes, Jackie.
Sorry, me and Paola, my colleague, can work with you to help you when you've decided your topics. We can develop a project plan to support that, so we can look at the meetings that you've got, the items that you've asked for example, home care. We can look at which monitoring reports would come to committee, and then the work that's been offered by colleagues on the policy development, which I think would not happen at a committee, it would be separate. But also, when you've decided, we can work with you on how you will do the scrutiny. So we have an appendix that we usually put in this report, Appendix 1, different methods for carrying out scrutiny work. We can give you more information about some scrutiny that's worked well at this council that you might want to look at. So one of the committees had a virtual conference last year on, it was the Housing and Communities Select Committee. They had a virtual conference with housing associations and residents, so we can let you know about things that have worked well here for scrutiny, but also things that have worked well for other councillors, so we can support you to doing things outside of the meetings as well. But I'm very mindful that councillors are not just involved in the scrutiny committee, that they have other committees that they're on and their ward work, but that's the support we can provide you to do your scrutiny.
Thank you, Jackie. I think that's is good. And on this item regarding the support, our committee member, Councillor Spalding, suggested, in line of what Jackie just described, he just sent me that he would like, and he's happy to lead, to investigate, because he's so passionate, I know, about health impact of air pollution. He's even happy to conduct like a half-a-day conference involving different stakeholders, and this is where the governance team can help us in even setting up this kind of workshop. I won't call it a workshop, it's not a workshop, it's more or less like seminar towards conference environment where we can scrutinize and for our council work here to be fully focused in terms of answering and supporting, getting answers. So this is another thing we can expand to work with the governance team. If you are happy with that proposal, Councillor Atkinson, yes.
We need to start to be clear as to what we are and we're not interested in. Speaking for myself, for the reasons already given, I don't think that the health impact of air pollution needs to be our priority. Neither do I think vaccine hesitancy and health inequalities. So I would take those two out. In terms of the things I am interested in, which I think maybe other people, public health budget and outcomes seems to me the thing I would most like us to spend time on.
Okay. Yes, Councillor Williams.
To assist the process, may I formally propose that we do the following topics, and this does not exclude others, which is home care, would be, don't need to agree how it's going to be done, but I appreciate the support of Gareth Wall in this, and also, as Councillor Atkinson has said, the public health budgets. So that's a formal proposal to this committee.
So we have two topics. The second one is proposed, seconded, so we have two members of the committee in agreement. What about the rest of the committee? Vice Chair? What is? I know you want the transition. Yeah, okay. So, if you are not in a full agreement, or if you are in agreement, let's say, on the positive aspects, but if you are hesitant, I'm happy to take this one by email. I mean, here, public health budget and outcomes, this really, we can look at existing data. We are all constrained by how things being spent, the quality of that spending is. There is a lot really we can probe into. So I will leave it to you before I give out my decision. Councillor Rossi, please.
Yeah, just to say that you don't have to decide here and now tonight, so you can carry on talking. The other thing is when the mental health in North Kensington working group has got a bit further and concluded, there will be space for another working group. It's only capacity of officers and councillors that limits it. So, you know, that's going to be, I would have thought, I don't want to kind of set a timetable, but I would have thought that would be concluding sort of this side of Christmas anyway. Sorry, I'll shut up now. Okay.
Thank you, Councillor Rossi, for the contribution there. Councillor Atkinson, please.
That's very helpful. I'd therefore like to add to Councillor Williams' proposal that once we've dealt with mental health, I would then want to put Councillor Addenbrook's proposal as the next item. So that would give us 3.
Yeah.
And Chair, can I just add that, in fact, some of that transition work, I think, will come into the mental health working group anyway. It's then just looking additionally at the SEND.
Yes. Okay, I think that's quite helpful. Makes sense. So we have one item, a spare one on the agenda, and then so shall we agree on public health budget and outcomes if you want now, or it's up to you? The committee agreed as a second item to be tackled? All right, you can see nodding, so we are all for agreement there. And on the waiting list as a provisional item is the transition, could be coming as part of the working group as we progress. Thank you for that. And I'm happy with that outcome. It's excellent. And then I will work with the especially understanding the mental health and the working group outcome and and how this is going to be integrated in the new integrating system emerging. Hopefully we can catch up by the end of this year how the ICS progressing, so we can capture. And it's open to you. It's, at the end of the day, it's your decision on the next item. But definitely, we have a definite one to go for, the home care services for the next committee meeting. So that's excellent. We start preparing for that. Yep. Thank you very much. Let's conclude this working group. I really am grateful to that discussion and conclusion. We go to item A9 now. I don't have any item except if anyone want to raise specific points, you're welcome at this stage. No? Any officers' comments? No? All right, thank you very much. This will conclude this meeting for Adult Social Care and Health Select Committee. I'm really grateful to everyone for their patience and attendance tonight, and to keep everyone safe and minimize the COVID. Please keep your face covered when we finish and leave the building. And chat outside if you like, but please avoid chatting in the building. And that's conclude this meeting tonight. Thank you so much, and stay safe, keep well.